Martel here from Health Quest and Overhead Athletic Institute. Today I'm working with Clayton. I worked with him pre-operatively, and he ended up having a labrum repair where they had to actually tack a portion of the labrum down. And you can see he's lost some of his internal rotation. He's lost some of his horizontal adduction. So you see he goes into horizontal adduction, and the pathway of least resistance, he goes into external rotation. So still a little tender to the mobilization pressure, but so I'll often start with activation into internal rotation. So what I want you to do is I want you to help me take your thumb to the floor when I go to you. So you're helping me a little bit, and in that position I've got a little distraction and a little posterior presence. So you're trying to actively mobilize the shoulder in the direction that it doesn't want to go, so that it stays centered. So you can see if he internally rotates, he wants to cranially migrate and anteriorly migrate. So you have to actually push the opposite direction. And then at the same time, I'll go to the insertion of the infra and the teres, and I'll assist in doing a functional massage in that direction. So rather than just going into an immediate mobilization, I'm doing something to try and assist in him centering the humerus inside the glenoid fossa. So in that position right there, just after doing that little bit, I drop him down. It's a little bit better than it was before. But you can still, he wants to anteriorly migrate, which often is the case with labrum repairs. So now from here, I'll distract just a little bit. I'm going to ask you to push your wrist up into my shoulder. Go ahead, push and relax. So the key to mobilizations is making sure that you're taking up all the slack so you don't have to apply as much force with your angulation or your direction of force with your mobilization. So now wrist up and relax. So I've got him abducted. Now push your shoulder up into my hand and relax. One more time and relax. Now internally rotate, push your thumb to the floor, push your elbow out of your shoulder, out of your socket. That boy. Now push your shoulder to the sky and relax. Internally rotate again for me. You got to push your elbow to the side, push your elbow to the side, push it out of the socket. That's it. And good. Nicely done. That's way better than last week. There we go. So when you're doing mobilizations, you got to understand everything that you can do to try and assist in getting that shoulder to follow the path of least resistance is what you have to do. The number one thing that's not done right in physical therapy for shoulder athletes is complete restoration of passive range of motion so that the shoulder can articulate in a direction that doesn't cause mechanical impingement. The impingement leads to labrum tears. That's usually a malposition of the shoulder in the socket, or timing, EMG timing, in the throwing motion. So now we'll go into horizontal adduction. So you'll say, okay, I test him. I just let him fall, I see what happens. You can see the shoulder want to migrate towards his ear, and he goes in a little external rotation. When does that happen? Then I'll go to the other side, and I'll do the same thing. I have him cross here. Now he's about 35, 40 more degrees across his chest. You don't see any internal rotation or external rotation. You don't see any cranial migration. So it's easy to test, but now you know there's the path of least resistance for that shoulder. So what do I have to do? I have to apply an inferior force while I'm abducting or flexing the shoulder and internal rotation. And I have to apply a posterior force. So oftentimes I'll have multiple people do mobilizations with me because you can't control for it all. So now in this position right here, what I want you to do is I want you to push your elbow to the sky, up, and relax. He likes me a lot on this one. Wrist towards the wall behind you right there, over your head, and relax. Now help me go towards your left with your elbow. So now in this position, I'm applying a little bit of a posterior force with my armpit, an inferior glide with my shoulder, with my wrist, and I'm not letting him go towards his ear. Wrist to your, up to the, over your head again. And relax. Now rotate your thumb towards your left pocket. Go. This is gonna stink. Go across to the left. Go, 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 go. Good. Yeah. And now, better. So I don't see as much external rotation. And oftentimes you're not going to eliminate all of that. You know, the overwhelming majority of shoulders, you're going to have a little bit of an internal rotation deficit. The question is whether it's pathological. But in therapy, you want to do everything you can, and every exercise you want it directed at eliminating that And that's the specificity of exercise and the specificity of mobilization. So when you're doing horizontal adduction, internal rotation, and you can see I'm still looking at how her shoulder glides in the socket with like 30 to 40 degrees of internal rotation. And I still feel that it doesn't want to go that direction. It doesn't want to go posterior, inferior. So I come over to the other side and I compare it. I put in exactly the amount of same internal rotation, and I just, yeah. So there's a lot more. So mobilization is 3-directional. Sometimes it's compression, sometimes it's distraction, sometimes it's lateral traction when you're doing horizontal adduction. So you got to watch how the shoulder moves so that when you're doing your mobilization, you're doing as much as you can with each one and then testing it and retesting it so that you actually see a difference. Now, that's significantly better. I don't see as much anterior migration, and he's got about 45 internal rotation. So, you know, with someone who's, what are you, 3 weeks out now? Almost 3 weeks out, 3 weeks out. You gotta be a little bit careful. So I'm gonna take them all the way into internal rotation. And now I'm gonna apply a little bit of posterior, inferior, medial force, because I wanna protect what the doctors did. Sometimes you do a little lateral distraction, you're putting more tensile load on it. So I compressed it into the socket. Now I ask him to push your wrist up into my shoulder and relax. Now suck your shoulder in the socket. Suck it in, there we go. Now rotate your wrist to the floor. Doesn't hurt as much as the other one did it, see? So you're still getting an effective mobilization. Wrist up, suck that shoulder in the socket. You go, beat me. Push your shoulder to the ground. Push your shoulder to the ground at the same time you suck it in. Good, and done. Boop. Way better. So you can see, each manual treatment, you want to do something as much as you can to try and improve the active range of motion and create a better pathway of least resistance. You can do exercises all day long for the infraspinatus, the supraspinatus. If they can't control the position of the humeral head because the stiffness of the humeral head is more powerful than their contraction direction, you're wasting your time. So you have to restore passive range of motion in the shoulder completely so that you see as little deficit as you can. And it's the #1 thing that makes doctors happy easy too. Doctors can explain away weakness, they can explain away pain, but if the shoulder doesn't move well and they come back to their appointment and the shoulder's not moving at all, usually that's when you get a call saying, okay, what the heck's going on? Especially for a throwing athlete. Way better. How's that feel right there? Not as painful. So that's why, you know, where you're feeling symptoms is a result of actually specific traction forces being placed on the shoulder because it's stiff. When you do the mobilizations in the right direction in combination with tissue heating techniques, contract, relax, sometimes I'll have them do a bridge to try and get me to get more range of motion. Then you put them in exactly the position, exact same position that caused the symptoms, and they won't have it. So, and that's experience. Don't let me push to the center. What do you feel? So, I mean, a lot of times you can do a resisted test prior to mobilizations, put them in exactly the same position that you did the resisted test in, and you'll see a difference in their pain or an elimination of their pain, which is why effective mobilizations are everything, which is why every exercise that we do in the rotator cuff complete, every exercise we do in the corrective exercise component usually has some aspect of it centralizing the humeral head in the socket. You have to have that as your #1 focus. And then when you combine that with something where people are learning how to throw in a way that gets their arm in the right spots at the right time, you have the best chance of being effective. So with that being said, we're going to actually go in the gym and he's going to do exercises now. Okay.